All right, we are live now. Good evening, everyone, and welcome to the first webinar that Peerhear is holding. And we are very blessed to have the opportunity to have this webinar with the guys from Lived Experience Australia. But before we kick off, what I'd like to do is just to do an acknowledgement of country so that we acknowledge the people and the lands that we are meeting on. So I want to get this right. So I'm going to read it. So where is it? I haven't got it here. Have I got it here?
Would you like us to
Here
do
we go.
it?
Here, now I've got it. Before we kick off, I'd like to acknowledge that this meeting is taking place on the traditional lands of the Gadigal, that's where I am, the Bundjalung, that's where Chelsea is, and the Ghana people, that's where the Lived Experience guys are over in South Australia. And we pay our respects to elders, both past, present, and future. Okay. So let's move on. So, guys, thanks again for joining us. And look, I'm really excited to be doing this. As I said, it's the first one that we've done with Peerhear. Peerhear, we're still very new as a mental health online support platform. And I guess just to introduce Peerhear, my name is Peter Burge, and I am the founder of Peerhear. And along with Chelsea, who's joined us, she works for the Peerhear team. And we offer online support sessions on a one-on-one basis and a group basis, and everyone that is involved with Peerhear has a lived experience of mental ill health, myself included. So again, very happy to be joining everyone here. And what I might do is just hand over to the guys at Lived Experience Australia. Oh, actually, right, let's hand over to Chelsea first to introduce yourself. So Chelsea, go ahead.
Thanks, Pete. So as Pete mentioned, I'm a consultant with Peerhear, lived experience practitioner. I've got a significant, unfortunately quite broad history of lived experience in mental health, but that actually equips me very well to be able to help a broad range of people coming to Peerhear with all manner of different mental health concerns. And I've got an interesting background as well in the health industry that helps me to be able to have some really great counselling skills to sort of wrap up into there as well.
Fantastic. Thank you, Chelsea. Okay, Jan.
Yes, thanks, Peter. Look, I'm Jan McMahon, and I'm the Executive Director of Lived Experience Australia. Look, we're a representative organisation for mental health consumers and carers, and we were formed in 2002. Our core business is advocating for systemic change, empowerment of consumers in their own care, promoting engagement and inclusion of consumers and carers within system design and the planning and evaluation of those services. And most importantly, we advocate for consumer choice, something that certainly comes through in the missing middle, and also in missing middle research, and also for family and carer inclusion. And I'm also thrilled that the lead author of our missing middle research, Christine Kane, is with us also. So Christine, did you want to say hi to everyone?
Hi, everyone. Thanks for joining us. So, yeah, as Jan mentioned, I'm the lead author on the missing middle research that we completed. I've worked in mental health and mental health advocacy for about 15 years all up. I started off working as a social worker in rural mental health services and then sort of in not-for-profit counselling. But majority of my time has been spent in mental health advocacy with Lived Experience Australia. So I'm a carer and, as I said, also a social worker. I've done quite a bit of research for Lived Experience Australia over the years, but I have to say by far the missing middle research was the most confronting and complicated and very in-depth that I've ever come across, and it was certainly a privilege to have the opportunity to work with Professor Sharon Lawn on analysing all of that data and reading every single comment that came through.
Great. Thanks, guys. And you might notice the ticker down the bottom says #no more missing middle. So if you are on Facebook or YouTube or Twitter, please use that as your hashtag if you're watching, just to spread the message. And it's really, it's a great message for us as Peerhear, because the research that has come about from, as the data has been washed by the guys at Lived Experience Australia, is that is why Peerhear is existing, because we've found that there is a gap in the service provision, and this is why Peerhear is trying to fill that gap. So what we're going to do is we're going to go through 5 or 6 topics, everyone, just that came out from the... Oh, I've got an echo. Make sure all your Facebook's turned off. Was that you, Chelsea?
Yeah, sorry, it just came through.
Okay.
I've just put it on mute. It just came up as a notification. It's good to know it's working.
It is working. I can see how many, we've got comments and everything. We have 5 or 6 topics that we're going to come, and these 5 or 6 topics are ones that were very prevalent throughout the data that Professor Sharon Law and Christine went through. So the first one we're going to start off with is one that's can be a little bit tricky, but is discerning between lived experience support and clinical support. And I guess I can kick it off by saying that everyone on the Peerhear team has a lived experience, as I mentioned, and we use all our lived experience to provide the hope and our own experience in showing, I guess, the people that we're trying to support, that there is a way to get through what you're going through. Chelsea, did you want to say anything about that, or Christine, or Jan?
No, look, that's fine, Peter, and I think that's one of the things that's come out quite strongly in the research. But look, just for those folk who may not be aware of what the term the missing middle is, perhaps I might just spend a minute or two, if I may, just sort of talking about that and Lived Experience Australia's research. Is that okay? And then we can kind of look at more of the details.
Absolutely.
Yeah, so look, the missing middle is a term that is gaining in popularity, really, and it talks about the folk who are either too complex or too severe, too enduring to be treated by primary care services, yet they're deemed not sick enough to access specialist mental health services. And what makes this data and this missing middle research from Lived Experience Australia is what's been missing in all of these discussions, and that is actually national data from the actual people this refers to. So this is a first for Australia, and so it now brings those voices. There are 535 participants into the discussions and reflects their experience. So what we can say is that the missing middle gap is real. It's far more than just a term. People do need significant care for the time they need it, when they need it, and if they can't get that help, they very often deteriorate into crisis with very dire consequences for themselves and their families. So we can really, at one end of the mental health system, people are actually getting the help and the support they need, but more so at the other end, they're not. So the federal government, through Minister Hunt's, made some significant increases to a number of the funded services over the past few years, particularly targeting areas of need. But very clearly, there are some real gaps, and Christine will talk to the access issues, the fact that many people said they wanted peer workers, and that's where Peerhear comes into it, Peter and Chelsea. So that really potentially does support what we're saying here. So I just thought it was important to sort of put a bit of context around our research and what we've actually found. So thanks for that opportunity, Peter.
Pleasure. I think that's a fantastic thing to do, and it's really framed what we're going to be discussing from here on in. Christine, did you want to?
Yeah, look, I was just going to say that for me, what came out really strongly in the research from quite a number of both consumers and carers and their families was the need to have support from people with a lived experience. So whether being a lived experience in the system themselves as a consumer, or caring for someone, or having a family member that is going through that. So there was a lot of mention of peer workers and lived experience workers, and it particularly came up in terms of keeping people engaged in services and to support that re-engagement. So yeah, there was definitely a lot of mention of peer work as a definite need, and also as a gap. So a couple of people had said things like that peer support provides social supports to assist with isolation, and community supports outside the mental health team venue. So it's often provided outside that clinical setting, where you could be meeting for a coffee or a walk, or meeting in their own home where it's safe. But having an external group or connection or peer that's not linked with the mental health service specifically necessarily, some are, but having an independent peer worker is something that one of the comments that someone wrote, saying they'd really like to access peer support but can't at the moment. And those that have had experience with peer support talked about the value that's provided for them to be working with someone and supported by someone who truly knows what they're going through in terms of having had that experience themselves, and whether that's not necessarily the mental health or the mental illness experience specifically, but navigating the system and dealing with the issues within the system, and having that direct experience is really, really valuable for people.
Thanks, Christine. Chelsea.
Yeah, everything. You might have seen me nodding my head in agreement throughout Christine's. What she shared with us just now is because that's exactly what I hear on the front line as a peer worker. As recently as Saturday night, I was in a person's home. So this Saturday just gone, they were in crisis. They were wanting to avoid having to present to health services. So I used my skills as a lived experience practitioner to support that person and basically work towards what they want. So it's also always a person-centered approach, person-centered, person-led, and got her what she needed. And yeah, was beautiful, lovely, excellent outcome.
Yeah, excellent. All right. Let's move on to because I should have mentioned we've got an hour for tonight, ladies and gentlemen, and we also have 15 minutes at the end for questions. So we'll be talking till 6:45, and then we'll have some questions at the end. So the next one that we wanted to talk about is that 40% of consumers reported that they could not access support within a reasonable time. And I guess one of the, with Peerhear being a digital telehealth service, that is one of the barriers that we wanted to take down. What was some of the anecdotal evidence that you had, Christine?
Look, I think, as no doubt many of the people that are tuned in tonight would be aware of, waiting lists are a significant issue. Finding the right support. So even though you might be able to access some support, it's not actually the right support for them. Not being able to afford support, all of those things impact on getting access in a reasonable time frame. I wanted to just share a couple of the specific comments about access, if that's okay.
Absolutely.
So one consumer talked about there's no services between a psychologist, too ill, and community mental health, not ill enough, and also very limited and unsuitable for me. I'm very low on trust after my experiences and can't tolerate decisions being made behind my back. Others talked about they've got limited choices in their area, and even the best are not necessarily right for them. Another consumer said it took months before she even figured out the system and felt capable of making and attending an appointment. So even though the service might be there, if people don't know how to access it, that's going to impact on their ability to access as well. Waiting times to access a psychologist are ridiculous, says another one. And a carer commented, that there were access issues because there was delay from being pushed from one service to another, and delay because they were the wrong age, and delay because the assessment team was new and not able to identify the issue, and delay because services didn't take on new patients in the lead up to Christmas. So, you know, access is definitely a significant issue for people. There were certainly a number of consumers that talked about the fact that they had a very long-term relationship with the person that's treating them, that they've got a direct phone number to be able to access that person when they need to. But unfortunately, those comments were pretty few and far between. There was obviously quite a lot that said that they just weren't able to access support, and certainly not in the time that they needed it.
Christine, have you got any thoughts on? Sorry,
Chelsea or
Jan or Chelsea?
Well, we've known that access is an issue for many people in terms of long wait lists, and this is face to face, and now we're finding even with telehealth that there can be some wait lists there. So I think that's an important factor that we have to look at, and so you know, if there's alternatives that can be provided, then I think that's a good thing.
Chelsea, what's your experience been? You know, working in the front line with wait times and I guess people being pushed from service to service.
Yeah, well, my experience as a lived experience practitioner or peer worker, as we say, is that you're trying to be as accessible as possible, because often people are in an acute phase and, you know, they can't wait. And this is what I'm hearing. I can't wait, you know, 2 weeks, 3 weeks for an initial consult, even 6 weeks or more, you know. So, and this is the reality of the wait times just in my region. So I'm not sure what that reflects elsewhere in Australia.
I think
so being able to.
Sorry, Chelsea. I think that's quite good actually, because it's about 6 months in other areas.
Right. Okay. Well, that's really, for where I am, then that's really great then. And that's really sad to hear.
It's still not good.
No, it's still not good. Comparatively, it's great, but as a you know, benchmark, that's not great. We want to really be able to have people accessing it when they need it. And when you're in acute mental health crisis, that is an immediate need, you know. And I know that the hospitals have these, you know, I've been involved in a lot of review processes from the mental health, within mental health, and I know that the hospitals are wanting services that can help keep people out of hospitals. So, you know, there's plenty of room for us to work within that space.
Yeah, I guess one of the things that has been, I guess, one of our catch cries, if you call it that, is that your mental health doesn't wait for an appointment. And
no.
So at any one point, you know, that when you're in the crisis, or I know that from my own experience when I'm having my moments of mental health, is that I very much am able to sort of, and it mightn't come out in the most articulate manner, but I can get my feelings out of my head really, really well if I'm in that moment, or they can observe me in a way that I think gives them more insights, gives the peer worker or whoever's supporting me, gives them insights into what's really going on at them in that moment. And if you think about if you're waiting 6 months or even 2 weeks or a week for an appointment, things change from that crisis moment or that moment of crisis to, you know, you could have talked to a friend, or you could have talked to your parents, or you know, even talk to someone online or Lifeline, and things sometimes mightn't seem as bad. And I can guarantee you, and I know that working with psychologists in the past, that people have not shown up for appointments when they're made in the future because of us thinking that everything's okay now, just because we're not in that exact moment of crisis. So I think, you know, all those comments were really great and valid. So the next one I wanted to move on to was this one, that from a carer's perspective, that 53% of carers reported that support was not provided for the right length of time. When thinking about the MBS 10 sessions, and then sometimes I think now it's the 20 sessions. What are some of the insights out of the research piece that you did there?
Look, I have to say that the number of subsidised sessions came up very frequently in the research. That at the time that we did the research, it was 10. So 20 is certainly an improvement, but still difficult, because if you're looking at sort of intensive support, it just doesn't stretch far enough when you're looking at, you know, mental health over a spectrum and over time. But look, there was certainly a lot of carers that said that either the person gets discharged by the service too quickly, or they may disengage with the service because the service isn't the right service for them. And then there's no follow-up, there's no referrals, there's no touching base to see how they're going, or perhaps why they didn't go to their appointment. So, you know, the impact of that becomes quite significant. One carer had said that mum gets discharged very quickly from services, and she's never been linked with proper therapy for her problems. She just gets managed for a short period through phone call risk assessments, and then quickly exited from the service. People don't try to come and see her at home, and they never contact her family for input. So I think one of the big things that came out for me in the research as well was the families not being included in the discussions about support for the consumer. So the family knows what the person's like when they're well and when they're not well, and generally are in the best position to be able to say how they're going on that spectrum and whether they are coping or not. And often what happens when people are not supported for the time that they need is that they go home to their family, if they're lucky enough to have family or carers around them to support them. And so the onus is then on the family to provide that support, which, you know, is incredibly hard if they're also dealing with their own things. And I think one of the big things that came out as well is what happens if people are not supported for the length of time that they need. And the impact of that is generally that they go back into crisis. So a lot of people made comments of things like, I do all right for a while and things are all going well, but then when things start to deteriorate, I've got no access to a service. I'm not connected with a service. So I have to start all over again, and I have to retell my story, and I have to go on new waiting lists. So there's no sort of continuity when I'm going, you know, in and out of crisis. So if there was actually someone there to support me along the way, it might help to connect me back into the services I need when I need them. So that was, quite a significant range of comments related to that, I think.
So just speaking of response time, and I just reflected on the comment I made about having questions at the end. We've actually got a really good question or a comment that's come up at the moment from Kim, and she said that I found as a carer that I was not listened to, not taken seriously, not included, and this had a significant impact on the care provided and my son's engagement or lack thereof. Just for some context, Kim has commented here that she's a carer, obviously, and has a son that's suffering with some AOD issues. So, you know, what is that ringing true from your perspective?
Yes,
absolutely.
Yes, and look, there's a point that I'd like to make too, and I'm speaking to Kim and others here, that someone doesn't have either a mental health issue or mental ill health, a disability, or drug and alcohol issues, generally in isolation. So it affects the people immediately closest to them. It could be close friends, it could be work colleagues if people are working, etc. So that's a point that I always keep in my mind when we talk about people with mental ill health. And I think what's really important these days too is to understand that carers often or families or friends look after or support, that's the term I'm looking for, support people with mental ill health without any experience, without any information to help them. They don't know side effects of medication. Half the time they're not even aware of what the diagnosis is. So we do a lot of work at Lived Experience Australia for carers. So one of the things that families or carers or supporters should really understand is that you at the very least have the right to provide information. I think that's, yes, and I think that's really, really important. The Carer Gateway is good, and thanks, Sarah. But I think that you need to understand that you know the person you're closest to better than anybody else, other than the person themselves, of course. So you can certainly have the right to provide that input into the whole, that background information that is often lacking, particularly with clinical services.
Chelsea, did you want to comment?
Oh, just to echo the same findings, that carers are left out of the loop a lot of the time, and also they're not actually provided with support themselves. They're doing a lot of the heavy lifting, for lack of a better word. At home, the ins and the outs of everyday care for people that are living with mental ill health. So not a lot of people actually that I've had experience with helping know about Carers Gateway, for example. And so the carers, they're at real risk of mental ill health in themselves and burnout and all those sorts of things. So we do need to be caring for the carer as much as we are caring for the person with mental ill health as well. Absolutely.
Well, great. I've just learnt that I didn't know that the Carers Gateway was around. So thank you to Sarah Ann for sharing that, because it's always within these settings that we keep learning.
I think one of the key things is to remember too, is that triangle approach. You have the person with the lived experience, you have the families or the carers that are close to them, and then the support person, whether that's a clinician or a peer worker. And there should be that kind of, sharing of information so that we can all come together to support the individual with, poor mental health, and get behind them and support them. I think that consolidated approach probably brings one of the best results.
Yeah, and
absolutely.
Jan has said here, in an ideal world, consumers will be linked to a person in the mental health system who stays in contact with them and their family, and when a crisis occurs, has the background to know what is needed in a hurry to plug the consumer into the appropriate care quickly. So thank you, everyone who is commenting. It's helping us with this webinar, obviously being interactive, but also really showing that the research and the findings that the guys have done through the missing middle is really spot on and hitting the nail on the head. So what I might do now is just go over to our next banner, being one that Jan just commented on, and the lack of communication and collaboration between health professionals. And as when I'm talking to people, friends, about Peerhear and what we're trying to achieve, it's almost and using there's a dinging sound. What's that dinging sound?
Sorry, that would be the clock in the background.
Okay.
My apologies.
That's all right.
It's 6 o'clock here in Adelaide.
That's all right. We are live. We're going live. Live television, as they say. You thought the Telstra analogy, and obviously it's not. Well, sometimes Telstra can cause my mental health to be terrible, but you don't want to be saying the same thing again and again to your mental health support, and the frustration that would be garnered from doing that would be obviously a huge block to people to keep re-engaging. What have you found, Christine or Jan?
100%. 100%. People talking about not just having to retell their stories, but relive their trauma.
Mm-hmm.
So in telling your story over and over again, you're reliving the difficulties that you've been through and the difficulties you've had with the system over and over and over again. There was a bit of a, I guess there was a mixture in terms of that lack of communication and collaboration, in terms of not just retelling your story, but not getting referrals to other services. So when you're discharged from one service, you're then not referred anywhere else. So you kind of go into nowhere. there's this empty space, or you go back to, you know, family or friends to support you, because there's this lack of communication after discharge. So it's a mixture of, you know, while you're there and whoever's treating you working together with others that are treating and supporting you, so that it's not done in isolation. There's certainly came out that there's a lack of that collaboration between those that are supporting you, which I think is a huge issue. A lot of people actually then use the term "I fell through the gaps." So in their comments about people working together or having, you know, referrals if they're no longer eligible for one type of service, they use the words "and I fell through the gaps."
And look, I think also if someone, for example, has a psychologist or psychiatrist in private practice and then needs an admission to an inpatient setting in the public system, medications can change, diagnoses even can change. So, and there seems to be very little of that collaboration and certainly the communication that takes place. And look, I'll just, sorry, I was just reading the clip that came up from the bottom. Look, I'll just give you a very quick personal story, in that I was seeing a GP, a mental health nurse and a psychiatrist weekly, and you'd think, oh gosh, that's over servicing, and perhaps it was, but I have to say that I was you know, really in a bad place, and so there was no communication between those three, even though it was on a weekly basis. And so there was at one point that I was very highly suicidal and came very close to taking my life. And it was actually just a priest who happened to call by that intervened. So, you know, this is really important stuff. And that's one of the things that I feel very, very strongly about. So I'm just reading the clip across the bottom from Irene, Peter.
Yeah. To repeat things is that, as what Christine mentioned before, you know, it can cause more harm to keep saying it over and over again.
Absolutely.
And there's another comment here that I'll bring out, is that from Irene again. Professionals needing to exercise, to be exercised, or informed, and to be trained in it.
Yes.
So that was something else that came out quite a bit, and it's interesting because I wouldn't have thought that necessarily this idea of trauma-informed practice would be a common knowledge thing amongst those that were responding to the survey, but they either used that terminology or they alluded to it in their comments, that it's absolutely critical, because so many people talked about the fact that they were traumatized by the service that was meant to be supporting them, and re-traumatized. So it's, you know, it certainly came out as a significant need for staff to be trauma informed in their practice.
Oh, absolutely. Yeah. And also peer workers, although those who have undertaken the certificate for in peer workforce, mental health peer workforce, and I'm sure the folk that are connected to Peerhear would certainly have a grounding in trauma-informed practice, Peter and Chelsea.
Yeah, I'll let Chelsea talk on this a little bit more than me, but yeah, that's, you know, our prerequisites for becoming a peer worker with Peerhear is obviously that level of training. Yeah,
I'd really like to hear a little bit more about that.
Well,
yeah, absolutely.
Chelsea, do you want to talk about that?
Yeah, absolutely. So the Cert 4 in mental health peer work is something that I'm currently undertaking, and it's certainly not my first formal training in counselling. As I mentioned earlier, I've been practicing in the health industry for some time, and in that formal qualification that I hold within that industry, I had a counselling subjects as part of my qualification that I have over there. So I interchange the use the two. But I've got to say, when it comes to trauma informed, the lived experience, of actually having lived the trauma, I find the most helpful tool that I can have in my, basket of tools to be able to sit with someone to actually have that visceral knowledge of what that feels like and how the sensations that you have in your body when you're experiencing a mental health crisis. To be able to draw on that lived experience is by far, the strongest tool I have. So unfortunately I have it, but it's become quite useful to be able to help other people to be able to work through what they're going through.
And just to sort of go through, I guess, the prerequisites to show the level of training for a peer worker, it is that there are some prerequisites in terms of, at least the certificate 4 in mental health and or the counselling certificates or qualifications, but the most important thing being is the lived experience, obviously. Also, there's two to 3 years of face-to-face experience as a peer worker, using a trauma-informed lived experience support model. Obviously, being very au fait with new legislation, new policies that the government is introducing to ensure that the people are able to access the care that they deserve and need at the right time as well. So just another great comment there too from Beat, that talk with a person and be interested versus judgmental when the person is expert on themselves. So let's move on, because I want to get to all our topics. And this one, again, is coming through with the comments that we're getting. The need for trust, empathy, inclusiveness, and being not judgmental in service provision.
Look, I have to tell you, when I was reading through the hundreds and hundreds and hundreds and hundreds of comments in this research, the amount of people that said that there was a need for particularly non-judgmental. So non-judgmental and being judgmental came up over and over and over again. And you would think that, in provision of mental health support, that would be a given, that it would be non-judgmental. However, those who are accessing it are feeling judged. And it came out incredibly strongly. The need for trust is a big one. So when we talked, when we looked at who people's main mental health support has been over the last 5 years and the reasons why, a lot of people talked about their GP being the main mental health support, and others talked about psychologists, psychiatrists, counsellors, etc. But the number one reason why the main mental health support is that particular support is because they trust them. And so this comes up as the absolutely most critical thing that in mental health support is that you need to be able to trust them, the people that are supporting you. And
look, I know from my own experience and working with Peerhear and peer work in general, it's only, they say, only there's I live on the beaches, and they say only a surfer knows the feeling. Well, only a person who has been through a mental health crisis knows the feeling of what you're going through, and to be able to associate what that has been like is very, very, very powerful, and it has been very, very powerful for me. Chelsea, have you got some thoughts on that too?
Yeah, same situation, absolutely, Pete. And unfortunately, a number of times I can share my lived experience here that I've been more than once in a mental health crisis situation. At my age, I was in mental health crisis, when I was quite young, and I didn't get the supports I needed at that stage. And echoing, the findings that we've discussed already in here. Not linked in with anybody post-crisis care was one of the big factors for re-injury for me. So to be able to actually make sure that I'm, as a practitioner now, like as a support worker now, making sure someone's got that connection, you know, once we end the discussion between me and someone else, making sure they've got a connection follow-up if that's not with me in a follow-up discussion, because we're not the be-all and end-all, and, you know, no one's got a God complex here. We don't think that we are the answer. We work with psychiatrists, we work with psychologists, work within the mental health, you know, with the mental health system. So that referral is super important to make sure that it's a really true holistic care, and then it's that person's getting what they need based on what they tell us that they need, not just based on the assumption that we know what's best for them, because we don't.
That's a great comment, Chelsea. That's one of the things that we don't want to create, you know, that one sector knows more than the other sector. It's I guess part of the research that has come out is that consumers and carers want collaboration, and, you know, it takes a village to raise a child. It takes a village to support someone. Go, Chelsea. I mean, Jen.
I was thinking of that quote, and I was thinking about it too, Peter. You're absolutely right. It does take, and for some folk who have complex needs, it does take the whole range of various supports needed, doesn't it? I think too, what we miss sometimes is a sense of humour. On my recovery journey, and I'm delighted to say that, you know, that has worked for me, was that used appropriately, a sense of humour by the practitioner is an amazing tool. There were many times, and I know some friends of mine ring me with these most dreadful stories, you know, that are and you kind of, you laugh with them, not at people, and it's amazing how it kind of helps turn that intense feeling around a little bit, so that people are able to see the other side, or you know, potentially can look and laugh too. There are many situations that, of course, are not laughable, and I'm not making light of any of those. It's just that I think one of the things that helped me was to have a practitioner who had a fabulous sense of humour, and it really did take the edge off lots of difficult conversations.
Oh, absolutely. I hear what you're saying there, and smiling in agreements, because ultimately when we're in that space, we're looking for a human connection. And a lot of the time that connection, you know, through humour, it works beautifully. There are other ways as well, of course, but yeah, absolutely. You always get that with me too. Always first the joker. But that empathy, that's always a really important connection tool as well, to empathise with people. And that's that true, you know, actually seeing them where they're at is really, really, really important, to sit with them in their distress. You know, and to actually connect, sometimes viscerally connect with them, you know, hug them, hold them, bring your breathing at the same level as their breathing, so that you can then help to modulate their breathing. It's such a powerful tool. Yes.
Well, things don't necessarily look so dark if you share them with someone, and you can pull out some points that might be, you know, looked at in a different way, and you can laugh together. As I said, I'm not minimizing anything or anybody's situation, so I don't want that to be misunderstood. But it's just that edge that can sometimes be brought to a discussion, I think, that might be, well, that has helped me.
So we've come to some question time, and what I've there's a question here from Tenny Burns, and I hope I've said, and sorry, Chelsea, you might just want to point your camera down a little bit, because this question's chopping you off, chopping your lovely face off. So maybe slightly off topic, but a huge concern I and others have is the first responders during a mental ill health crisis are AMBOs and police. AMBOs are generally compassionate and calming, but the cops are not. Trauma is increased by their approach, aggressive, violent, intimidating, and of course, sometimes they kill consumers. And look, I think that is a very, I think that's a huge concern. It's a huge concern for me, especially, as a parent of young people. What has come through in your experience, Christine?
Look, nothing in the research specifically, but I have to say I do some work as well with an organisation that provides training particularly for ambulance workers and Royal Flying Doctor Service and places like that, which actually supports them to understand what state people might be in and how to actually support them to approach them appropriately, to calm them, to certainly have the opposite approach to what Tenny has identified here. And I would love to see that sort of training provided to the police force. I don't know whether it is currently in different states and territories or not, but I know that it's certainly had a significant impact on the first responders that are accessing that support and that training.
And I think that the training has made a difference to a number of police officers, because some people would agree with you, Tenny. Others would probably say, well, actually, the police were very responsive in a very appropriate manner, and were in some cases more helpful than potentially some in the public mental health system. So, this has been the case for some friends of mine. Potentially they became known to the police, I'm not sure. But, at the very least, they're human beings too. And it's what I hear both. So I think training for first responders across the board is something that's incredibly important.
Agreed.
Okay.
And I can see that inconsistencies coming through in my work. I can see it just now in our prompts here, that we can see people coming in and commenting. Kim's just said that hers was the opposite. So there's no consistency there, and it would be ideal to have all of our first responders trauma informed. And I know that there's being involved in lived experience, review processes and things like that before. There's even been the idea floated that having a lived experience practitioner present with the first responders could possibly be, a workable solution to that as well. And I would completely happily put my hand up with that kind of experience, because I feel that we have so much to offer, to that true, like we were talking about before, that empathy, and even the humour, and there's all those tools that we have in those acute crisis times.
And I think you're absolutely spot on there, Chelsea. I think what Lived Experience Australia is doing is advocating for lived experience, people with a lived experience to actually be some of the trainers for the first responders, police and ambulance. And I think a whole lot more could be done around those particular issues from our perspectives.
I've got a great question here from Liz, and I know that Chelsea, I think Chelsea does know Liz Assa, don't you?
I do, very well.
Yeah.
Beautiful human being.
Yeah. I think I've chatted to her we emailed back and forth, but brings up a great, one of the concerns expressed by NDIS participants is that quality control and regulation in peer support work is hit and miss. How does Peerhear manage this? Do you have requirements for your staff? Well, I can say that, Liz, that Peerhear is currently just put in its application to become an NDIS agency or registered model of support, so people can start accessing Peerhear via the NDIS. But I guess from a quality control perspective, it's about supervision, and it's about we have a guy on board that I think many people might know here, Michael Burge, no relation to me, who is our Peerhear, our peer worker supervisor. And I guess that is like any my wife is a social worker, and she works at Royal North Shore Hospital, and she has supervision, I don't know, once a month or once a week, or whenever it is required. So that is one thing that we do, obviously, and with the rolling over into the NDIS, I know that for sure that from my perspective and Chelsea's perspective, and you could ask the staff, we are, have the utmost priority of being the most professional service we can be, with the consistent approach of peer informed and trauma informed peer work that we can, and knowing that, again, as Chelsea said before, we're not the experts in everything, and knowing that the right time to refer and the right time not to refer, and those are these innate skills that we learn by doing the training that we've been provided, and the experience that we've had as lived experience practitioners. So thank you for your comment, Liz. I will go to some other questions here. Just give me a sec. There was a long one here from. Here we go. This is it's a huge one. I might just read that out, actually. This is from Jan Lansdowne. As mentioned before, every consumer had a contact in the mental health system who coordinated care and kept in contact with the consumer. This could overcome some of the lack of communication, as well as helping in a crisis. It could be peer workers or mental health nurses. Probably don't need to have psychology or psychiatric qualifications. This would be important for those in the private system as well as the public system for treatment as GPs, psychologists, and psychiatrists. And I'll just try and see if I can get the end of it. Oh, we can't see the end of it there. But that is a good point that I wanted to bring up with you, Christine, because I know there was a private hospital part of the research that you did. Have you got any insights from that part of the research that you could share with us?
Look, probably not linked specifically with that, because with the private hospitals, the feedback that came through was generally that there was sort of more planned discharge planning to ensure that the person isn't kind of discharged into nowhere, but does have the supports around them that are needed. But probably not so much from the private hospital sector around that ongoing support, because that's not generally something that's provided. But there was certainly a lot in the research about the need to have someone to be able to touch base with them regularly, to help keep them away from crisis, I guess, by picking up on things when they're not going so well, and to make it easier to kind of reintegrate into the system when they're needing support. I know one of the comments in particular talked about that she had a social worker that would call her regularly, regardless of whether she said she was doing okay or not. And it was actually that social worker that then kept her going well over time and picked her up when she was starting to fall. And I think the thing is that a lot of people talked about missing appointments, not because they're well and don't need them, but actually often the opposite. But if an appointment's missed, generally nobody follows up as to why they missed it. It's on to the next person that's, perhaps it's an assumption that about the reason why they might have missed the appointment. But, a lot of people talked about that need to have that ongoing contact. If I miss an appointment, actually maybe there's a reason for that and things are not going well for me. So please follow up with me. Be persistent was used quite a few times.
Oh, yeah. Sometimes I feel like a broken record with people checking in, and that's really important, because as lived experience, I know I can echo those findings from the study that you're talking about right there, Christine. In the depths of depression, laying in the bed going, oh my God, I can't bring myself to get in the car, let alone drive myself to an appointment. And all I'm going to do is just stand there and sit there and just cry the entire time. So what's the point anyway? So yeah, 100%, if there needs to be that trust, what we're talking about before, developed with somebody, and we are positioned really well for that, as lived experience practitioners, because we pick up on those cues really well. with our lived experience, we've been there. Yeah, sure, you might be missing your appointment because of a genuine, you know, whoops, I double booked myself, but it's worthwhile checking in and making sure, you know, that there's not a more concerning reason for that.
Again, speaking from a Peerhear perspective, when you are engaged within, because we are a digital service, and obviously our data privacy records are very safe and secure and are not used in any way other than to support you, who is the one seeking support. But it's one of the things that we can do in a more efficient way is because we are digital, we are able to get the email and a phone number so that we can keep track of the people that are coming into contact with us, and you know, be able to put them on our email subscriber base. And we send, you know, obviously we send out EDMs that are not just about what Peerhear is doing, but what is happening with policy around the world and things that you can actually do to, like, say, for instance, having a morning routine to help you with your mental health, etc. And so again, one of the foundational reasons why we wanted to start Peerhear is for that digital recording of people being in contact with us, so that we don't lose track of someone just turning up to a shop front and then we never see them again, which could be from a worker's perspective quite challenging.
It's interesting, Chelsea. I was just thinking about your comment regarding, you know, sometimes you might be too depressed to the thought of even just getting out the house. We recently did some research around telehealth psychiatry, just a little bit side topic. But one of the things that talked about, and it probably supports in terms of accessibility, was that often, you know, if the person's just too scared to leave their house, or there's too much anxiety, you know, the anxiety that's related to going to appointments, or it is that, you know, they just don't have the energy to go, or the idea that they're going to have to travel for, you know, an hour and a half to get to an appointment and then go to the appointment and then travel all the way back, and how exhausting all of that sounds. There was a huge response in terms of the need for ongoing telehealth psychiatry. So I think that sort of speaks a little bit to digital services in this way to support that accessibility as an option. It's not for everybody, and it's not the only option, but having digital support available is certainly something that's very convenient and helpful for many people.
Absolutely.
Others will always prefer that face-to-face, you know, in-person contact, which is fine too.
Yeah, for sure. And I can tell you a number of accounts, you know, where when you come and consult with me with Peerhear, for example, you know, I've dealt with people. I've helped people who can't even leave their house. You know, they're dealing with agoraphobia issues, that their anxiety is that high. And you don't have to turn your camera on. You know, we can just have a chat. You know, I've had a lot of people, they won't, you know, I just say, look, and they'll be really nervous. The appointment will be sort of, you know, scheduled, and I'll send them a little text message or a little email going, it's okay, I'm here, leave your camera off. And then, you know, a few seconds later, they pop on with the camera off, and they just need that safety, you know, and that reassurance to know that I will meet them at the level that they need to be met to feel safe. And if that means turning your camera off, and, you know, whatever we need to do. Yeah.
Okay.
Look, I think it's 7 o'clock, and that's our hour. And I think that was a absolutely perfect way to end our discussion this evening. I would like to expressly thank, of course, Chelsea, who works for Peerhear, Christine and Jan from the Lived Experience Australia network or movement. We are both national networks that work obviously throughout Australia and offer our services throughout Australia, and again, very appreciative that of the research and the work that would have been a mountainous amount of work that you guys put into doing that research, because it gives services like us and others who are in the peer work field some real guts and some some great data to lean on, you know, so that we know that we're going down the right track and doing what we're doing.
Well, thank you, Peter, for inviting Lived Experience Australia through Christine and myself to participate on your webinar. First time we've done it via Facebook. We run multiple webinars, but this is the first time we've done it via this platform. So thank you for inviting us.
Oh, it's been a pleasure.
Thank you.
And, yeah, sorry, Christine.
No, just thank you.
Just before we do conclude, I'd just like to pay my respects and my thanks to 535 people who entered our survey. It was long, it was complicated. People must have spent well over an hour to complete all the questions. And if any are listening, there's a couple of things I'd like to say. Firstly, thank you so much. And secondly, Christine and Professor Sharon Lornan and myself read every single solitary comment. And I think that if you are someone with a lived experience, that I just mention, Peter, if I may, that if any of the content tonight has caused anybody any distress or concerns, to please ring Lifeline on 1300 11 14 or Beyond Blue 1300 22 46 36. Both lines are available 24 hours a day and 7 days a week. So, you know, I think that's important to put it out there.
And can I just add to that as well, Jan? I don't know whether people are aware or not, but we have, there's the SANE online forums, which are a 24/7 support. So we've got a link via our website as well under forums. So it's where you've got an opportunity to talk with peers, with like-minded people, but it's moderated by people with the expertise in the background as well as the lived experience. But it is something that you know, a lot of people get a great deal of support from. So if you are looking for something, I think it's definitely worth exploring.
And Peter and Chelsea, how do people contact you?
Peerhear.com.au. All our contact details are on there. info@peerhear.com.au. We're, as you, digital service, face-to-face, telehealth, and yeah, would love to assist in any way that we can. Just as another comment, your first appointment is, as we see, as a get to know you, and so it comes at no cost. So very happy to support anyone in any way we can, and we're available obviously by video as we're doing now, via phone and or text. So are
you available 24/7? Not
quite just yet. We're available up till midnight, but we're as we get to the point where, because we have received no funding as of yet. We wanted to get to the point where, you know, we were proved that this is a model that works, and we know that it works. And you know, when the time is right, we'll put our hand up. But in the meantime, we wanted just to show Australia and the people that are watching that there is a place to go for you to feel safe, and for you to get the support that you need in a non-judgmental and trusted way by Peerhear. So,
okay,
great.
Right,
Thank
guys.
you.
This will be recorded. We'll be sending it out to everyone who registered, and I hope everyone enjoys their night. Thanks again to all the participants who watched. Thanks to Alex Robinson, who was moderating for us tonight. Chelsea, Christine, and Jan, thanks again, and we'll no doubt see you soon.
All right, thanks. Bye.
Bye now.